Welcome. My name is Paul Vespa. I'm from UCLA, and I'm going to talk to you today about intracranial pressure. I have an algorithm. These are my conflicts of interest. The agenda for today's talk is to talk about the tiered approach to intracranial pressure, ICP treatment, talk about the use of multimodality monitoring, specifically intracranial pressure plus brain tissue oxygen monitoring, and to introduce you to the CIBIC Consensus Conference ICP algorithm, which was published in 2020. The approach to intracranial pressure treatment is usually considered to be a tiered type approach, where tiers go from tier 0 to tier 3. And in each tier, we do a number of standard measures. Generally speaking, we do uniform standard measures in all patients. That's considered tier 0. Tier 1 is where we have intracranial pressure being documented, and we do hyperosmolar therapy and CSF diversion. Tier 2 is where we start using sedation or paralytics or more normothermia. And Tier 3 is where we go to more rescue therapies, including decompressive craniectomy, hypothermia, or barbiturate coma. And we'll go through these as we go through the algorithm. So under the guidance of Dr. Chestnut and Dr. Hollyrook, a consensus conference was, international consensus conference was held, where we tried to look at what are the treatments that can be done and perhaps should be recommended in an algorithm for treatment of intracranial pressure. And we talk about the specific tiers of treatment. And the tiers of treatment in tier 0 really include standard treatments which try to reduce intracranial pressure in patients very early on, such as intubation and mild head of the bed elevation and analgesia and temperature control, fever prevention, putting in venous access, keeping cerebral perfusion pressure greater than 60, avoiding hyponatremia, and similar types of treatments, maintaining normal SpO2 or oxygenation. And what one can see here is that then one would move on to measuring intracranial pressure and using tier 1 treatments. And the tier 1 treatments are outlined here in keeping the cerebral perfusion pressure 60 to 70, using analgesia and sedation, keeping CO2 in a relatively low end of normal range, using intermittent dosing of either mannitol or hypertonic saline, using ventricular drainage to drain CSF, considering anti-seizure medication, and considering EEG monitoring. And the guideline really goes through it, details of how to use the guideline. It's important to read this document and what to do in between tiers, especially re-imaging the patient and considering surgical options. Now, this guideline is somewhat different than previous guidelines in that we discuss the use of combined intracranial pressure monitoring and brain tissue oxygen monitoring. Shown here in this slide, the brain tissue oxygen is this probe that sits in the brain and gives you a partial pressure of oxygen. And the general guidelines here are to keep the intracranial pressure less than 22 millimeters of mercury, keep the brain tissue oxygen between 20 and 50 millimeters of mercury, and consider abnormal brain tissue oxygens that are less than 20 millimeters of mercury. This is the appearance of the probe on a brain CAT scan. This is based in large part on the BOOST study. This is the BOOST 2 trial, which was published a few years ago, in which we're trying to keep the brain tissue oxygen in this 20 and above range and not letting it go below. In the BOOST trial, they outlined different kinds of conditions. Conditions in which intracranial pressure is normal and brain tissue oxygen is normal, that's type A. Conditions in which brain tissue oxygen is normal but ICP is high, that's type B. Conditions in which brain oxygen is low but ICP is normal, that's type C. And conditions in which both ICP is high and brain tissue oxygen is low, and that's type D. So in this CIBIC algorithm, we actually talk about the different types of conditions. And we'll go now to type B, that is high ICP but normal oxygen. And what you see here is when you have type B situation, you're going to focus on things that lower the intracranial pressure. Similar tier 1, that's very similar to before. Now we might lower the PCO2, mild hypocapnia. We might use neuromuscular paralysis. We might raise CPP. If things are not under control, we might then go on actually to do what's called a MAP challenge, or raise the mean arterial blood pressure. And then if things are not under control, we might proceed to tier 3, which is what I outlined before. Again, important to reconsider imaging and evaluating the patient. So this is type B situation focused mostly on ICP. Type C is where the oxygen is low, but the intracranial pressure is low. Now things are different. Now we are allowing the CO2 to be a little bit higher. We're allowing the PaO2 to be higher. We may actually change the ventilator to raise the brain tissue oxygen. We might lower our threshold, treat ICP a little bit lower, CSF drainage, increase sedation that may help brain tissue oxygen as well, neuromuscular paralysis, maybe raise CPP and see if the brain tissue oxygen improves, maybe use a higher CPP goal with fluids or vasopressors or inotropes. And in some cases, we might actually allow hypercapnia as long as the intracranial pressure is controlled. And you can see here some other options. Type D is perhaps the most challenging, in which we have high ICP and low brain tissue oxygen. Now it gets more complex because you're trying to control both problems at the same time. And here, again, we're trying to maybe allow CO2 to be higher, maybe using intermittent mannitol or hypertonic saline, allowing the brain tissue oxygen to be higher, increasing sedation, neuromuscular paralysis, perhaps raising CPP. But again, always towards an eye of both controlling intracranial pressure and brain oxygenation. Tier 3 then also comes into play because you may not be able to fix the problems, you may not be able to fix the problems by other means, and then you may have to get into some of these other rescue therapies. And one note here is consideration for giving a blood transfusion if the brain tissue oxygen is low, despite having a adequate PaO2 and cerebral CPP and MAP optimization. And you can look at that algorithm note in review. So in summary, this Civic Seattle International Severe Traumatic Brain Injury Consensus Conference algorithm is a tiered approach to control intracranial pressure. This ABCD model enables the use of 2 monitors, the intracranial pressure monitor and the brain tissue oxygen monitor, to understand physiology and to guide therapy. And one has to understand that this is a starting point, and this algorithm talks about this. Clinical interpretation is needed, and further best optimization at a local level is encouraged. And with that, I thank you for your attention, and that ends this presentation.